Welcome, everybody, to another edition of Coffee Talk right here in Port Jefferson Village. We're excited today to start a new series on health, particularly with St. Charles Hospital. And today we will be speaking to the world-renowned Dr. Ahmad. He knows this field best. He's performed over 10,000 bariatric general and endoscopic surgeries and over 30 years of experience. So let's dive deep with Dr. Ahmad. Welcome, Dr. Ahmad. It's a pleasure to have you today.
Thank you.
Thanks for coming and joining us.
Thank you for having me.
You know, we call this acid reflux. I've heard the term heartburn. I've heard the term GERD. But I have to tell you, I grew up in a half Italian family, Sicilian, and my grandfather used to say agita all the time.
Agita, exactly.
Like, you can't believe how much he used that. And he usually used that term when he was upset about something.
Yes.
So I'm trying to determine, do you think he had it, or was he just...
Well, I think you were just giving him a lot of agita.
That's what was happening.
Growing up, yeah.
Yeah, maybe coming home from the Long Island Railroad or something. He said, agita. He would say to my grandmother.
Yes.
So this is a very prevalent disease in our society. What percentage of people, Americans, do you think suffer from acid reflux?
So 1 in 5 Americans have acid reflux at some point, And I'd say 1 in 10, it's quite severe. There are 22 million people in the United States that are on medication for acid reflux, whether it's over the counter or whether it's prescribed. So it's a very prevalent problem. And 1 in 10 of these people will develop what's called Barrett's esophagus, which is a condition where the lining of the esophagus becomes precancerous. And therefore, it increases the risk of esophageal cancer. So it's a widely prevalent problem. It greatly interferes with people's quality of life. And it has long and very important consequences.
Would you say Americans are more susceptible to this disease because of our diet?
I think the modern American diet with our lifestyle, eating a lot at one time, eating more fatty food and spicy food from times, not that much spicy, more fatty food is a big contributor. And some of the things that have led to the prevalence of acid reflux in more recent years, I'd say over the last 25 years, we don't fully understand why it is becoming more and more common. And it probably has something to do with the microbiome, which is the bacteria in our gut. And this has become a more fashionable thing of late. We didn't really appreciate what our gut bacteria do to us.
So an American notices they have this.
Yes.
They don't know what it is. They just know they have, call it what you will, indigestion.
Mm-hmm.
They go to CVS, I would imagine, and they ask the pharmacist, what can I do about this? So what is the number one thing that people run to before they even go to a doctor?
The first thing people run to would be something like Tums. Mm-hmm. So what Tums does is it neutralizes the acid. Now, acid reflux doesn't mean you're making too much acid. A lot of people think you're making too much acid. You're making the right amount of acid, which is needed. No one makes too much. I mean, it's rare to make too much acid. What's happening is the acid, instead of staying in the stomach, is coming up the throat or the esophagus. That's where the problem is. But unfortunately, we don't have a good way of fixing that problem. So what people generally do is try to reduce the acidity of the stomach contents. What that results in is when the acid comes up, it's not as acidic, so it doesn't burn as much. And they think they've solved the problem. But liquid is still coming up.
I understand this completely. Yeah. So when they come into the doctor, such as yourself, how do you determine and confirm and prove that it's coming back up rather than just, as you said, producing more acid? What is the telltale sign that says you're having acid reflux? It's coming back up.
So it's a constellation of symptoms that we go by. And I'll show you some of the symptoms on the slide.
Sure.
But patients who have acid reflux first complain of heartburn, regurgitation, sometimes even difficulty swallowing. They also have dental erosions and bad breath. And then what we call extraesophageal symptoms, that means not related to the esophagus or the food tube directly, such as sore throat, shortness of breath, chest pain, and even asthma. So these are the symptoms we go by, and we say that these are triggers, likely to tell us that this is probably acid reflux. And then if they say it's relieved, or at least the heartburn is relieved with Tums or medications like that, and it's worse with with certain foods, with coffee, with chocolate, things like that, which reduce the pressure of the lower esophageal sphincter, then it tells us further that this is probably what's going on just based on the consultation. And then there's a series of tests that we have to run to confirm. But we usually do that only in patients who need further treatment.
Okay, so is there an MRI taken? What actually shows you in real time? Is there something that shows you in real time that they're having this issue?
And that's a very interesting question. The commonest way to assess it is to just do an endoscopy, where we put a telescope down, we have a look at the esophagus, which is the food tube. We see the lower end of the esophagus, where there's supposed to be a valve, which usually isn't working in patients who have acid reflux. So we see the effects of acid damage. So we call it esophageal erosions. We see those in the esophagus. And we can see that on endoscopy. But to actually see the acid coming up, we can ask patients to swallow a radio-opaque liquid and then ask them to bear down, and then we can actually see that liquid coming up.
That's amazing.
But really to confirm that patients' symptoms are coming from acid reflux. So some people, liquid comes up when they bear down, but that's not what's causing their symptoms. We have to do another test, which is called a Bravo test. This is quite a high-tech test. What it involves is me doing an endoscopy and leaving a little capsule like a chip in the esophagus, which stays there for about 48 hours or so. And during that period, it communicates by Bluetooth to like a beeper that they carry. And it tells me what was the pH or the acidity of the liquid that was coming up and whether the patient was having symptoms at the time. So every time the patient says, I think I'm having agita, then they press this button and I see whether there's a correlation between acid coming up and that symptom. So that tells us, that's called 48-hour pH assessment, you know.
This sphincter, this valve that you make reference to, we're like automobiles, aren't we, right? It's supposed to go one way and not go the other way.
Right.
That's amazing. So we're going to talk about some of the techniques. If this stays, these symptoms keep going on, we can't treat it with medicine. So let's talk about medicine first.
Yes.
From now Tums and CVS to what you might prescribe and why.
Yes. So we generally would just start with Tums or proton pump inhibitors, that is, things that reduce the acidity of the stomach. The problem with that is that, you know, this is a long-term problem, and you cannot just suppress the acid of the stomach forever, because when you do that, it has its own consequences. You know, God made acid in the stomach for a reason, and that is to break down the food and to kill the bacteria, to change the bacteria of the intestine lower down. And just suppressing the acid is not the solution. So this is a mechanical problem where the valve isn't working. And it demands a mechanical solution rather than just suppressing the acid.
Okay.
The problem is, until now, we did not have a good mechanical solution. We had mechanical solutions for more than 40, 50 years, which involved a big open operation and creating a new valve. But that was quite a severe operation. But now with the advent of minimally invasive surgery and with the advent of robotic surgery, we can reproduce that operation with greater precision and more effectivity, you know, with these small incisions in a procedure that takes about 45 minutes and can be done as an outpatient procedure. So what we're doing now is, instead of just suppressing the acid with medication, which the majority of people are currently doing, we're actually allowing the acid to stay where it was meant to be, but changing the mechanics of that lower esophageal sphincter, which is the valve, so that the acid stays where it was designed to be and doesn't keep coming up, and that prevents the problem. So let me show you, in spite of medication, as you can see on this slide, 62% of people did not have breakthrough symptoms, but 38% of people continue to have breakthrough symptoms, which means they're still regurgitating. And this is as expected, because even though that 62 that don't have breakthrough symptoms, they're still regurgitating, which means liquid is still coming up. It's not as acidic, so they don't feel it burning the throat as much, but it's still coming up. And if you look at the next one, the next slide here, this was a Gallup poll which showed that, 79% of people continue to have nighttime symptoms, and about 40% of people are dissatisfied with proton pump inhibitors, which is the medications like omeprazole, which is even available over the counter, but it is the commonest medication that's used to treat this problem. The next slide will show you that the majority of people are not actually happy with continuing to take medication for the rest of their lives.
There's some side effects with this.
There are a lot, there's significant side effects with this. And if you look at the leaflet, the product information, it says not to be used for more than 6 months. But I don't know anyone who's using omeprazole or Nexium or any of those drugs that can stop after 6 months. So long-term use of these medications causes osteoporosis, which then results in increased fracture risk.
Right.
And as the population gets older, they start having fractures. And then, fracture is a big thing, because now if you have a hip fracture, now they're immobilized and is the beginning of further decline. Then we know it reduces magnesium levels, which has its effect on various parts of the body. It increases the infestation of the intestine with C. diff, which is a very serious infection that's commonly seen in hospitalized patients. And then there's increased incidence of kidney disease. So, it damages your kidneys.
One thing leads to the other. There's no fix for...
Yeah, the drug itself is known to damage the kidneys, as you can see on the right of that slide. And then there's even claims that it can cause dementia. So there's a lot of things that one needs to think about before just staying on proton pump inhibitors for the rest of their lives.
Is this a possibility that somebody goes on this for 3 to 6 months and changes their lifestyle, around, really starts to eat well, and they're out of this? They're cured. Is that a possibility, or do we always see further possibility of surgery after this?
No, I think there's a possibility that if they lose weight and keep it off, and they change their lifestyle, and they don't consume things that reduce the pressure of the lower esophageal sphincter, which is things like coffee and chocolate, and people do want to enjoy those, and there's nothing wrong with wanting to enjoy them. But I'm saying if they're going to be able to follow that kind of a strict diet and lose weight and keep it off, and then their symptoms should be a lot better. Now, I would say that would be for the majority of patients. And there are some patients who also have a hiatal hernia that's associated with this, because for that sphincter or that valve to work normally, the stomach has to be in the right place. That means below the hiatus, which is called the opening in the diaphragm. Now, if the stomach moves up into the chest, then no matter what lifestyle changes they do, they'll continue to regurgitate.
Pressure.
Because of the fact that valve, that opening is too big. It's like a hernia, so stomach is herniated up. I have a lot of people who are skinny and they have severe acid reflux. They're regurgitating, in spite of not taking any medications and things. Those are patients who, not taking, things that would increase reflux. But those are patients who have hiatal hernia. So if a patient does not have a hiatal hernia and loses weight and can restrict their diet, then yes, they won't need any of these. But staying on medication for the rest of your life and continuing to regurgitate, in my opinion, is not the solution to this problem.
Quality of life.
Yeah.
I have a question. Do you see certain nationalities that are more susceptible to this than others?
No, not really.
You know where I'm going. If you're again with the Italian, you're eating constant red sauce and that type of thing.
I see what you mean. Yeah, certain lifestyles are more associated with it, but I don't think that we have any real data to show that certain nationalities are more prone to it.
Okay.
Now, obviously, people who are skinnier in the more developing countries, who are more on a vegetable diet, and things like that, they have less reflux. It's more of a Western problem more than it's an Eastern problem.
Okay.
Yeah.
Okay. What do we have for our next?
So the thing I wanted to point out is that patients who have severe acid reflux or significant acid reflux really just have two options. They could either stay on medication for the rest of their lives and continue to have nighttime symptoms and have the side effects of those medications, which are not immediately apparent, or consider minimally invasive surgery. This is a procedure that takes about 45 minutes for the acid reflux. And this second option is especially good for patients with hiatal hernias, which is a very common problem. So if I'll show you on the next one, this here is me doing a procedure called fundoplication and repair of hiatal hernia. That hole that you see right in the middle, that's where the hiatal hernia is. That hole should normally not be present. The fact that hole is there means that...
Can you point to the hole?
Yes. So this hole right here is the hole there.
That should not be there.
That should not be there. And that is this should be tight. So it allows the acid from the stomach to go into the esophagus. Part of that stomach has herniated up into the chest.
Is this you actually performing
This
the surgery?
is me actually performing the surgery, yes. Here on this side here is the crus of the diaphragm. That chocolate colored thing is the liver. That was the hole that I showed you. And we'll try to fast forward this if possible. But basically, we're freeing the stomach up. So this part here shows you how that hole is now being opened up fully. And this is the esophagus or the food tube. See, we've pulled it down. It was in the chest before. And now we have to close this opening because this is stretched too much. No amount of medication is going to close that hole.
Yes.
This really needs to be closed, with stitches. And that's the esophagus or the food tube. We've brought that down into the abdomen.
Incredible.
And now we've closed everything. See, now this is nice and tight the way the good Lord had designed it.
Yes.
And,
you want to bring it back. So,
yes.
Yeah, you've got to be for
And
surgery, right?
Yes. And then I'm going to show you how we create a new valve and we take the part of the stomach and we wrap it around the esophagus. So here I'm taking the stomach. We call that maneuver the shoe shine maneuver. You're going to see how this looks like we're shining the shoe on there. You get it? And then we can wrap that part of the stomach around it. That creates a new valve. And that prevents acid reflux. So in this operation, essentially, what we've done is we've closed that hiatal hernia and we've created a new valve. Now, these patients, 95% of them need no medication. After this. This persists for many years. So even after 5 years, I'd say about 95% of people are totally off medication.
Fantastic.
And
what's the recovery period for something like this?
So they usually go home the same day. They're walking around
Amazing.
right away, and then they gradually return to work. Depends on whether their work is sedentary or not. They could return in a few days. If they're doing heavy lifting and things like that, then it would be about 4 weeks. But the recovery is really very quick, and it's a question of gradually advancing the diet. Okay, so that was one procedure. You can see that hole that we have to close. And then we have another procedure that is simpler, and that's with the use of this device. It's called sphincter augmentation. So this basically here, you can see on the picture on the left of your screen, is it's a bracelet made of magnets, magnetic beads. And we place that in the lower esophagus. That works like a sphincter or a valve.
Yeah, this is amazing.
Yeah.
I thought whoever invented this is a pretty lucky person.
Yes.
Right?
Yes.
But here's my question, and I know you're going to explain it, but how do you know what tension each bracelet, maybe someone needs more tension than others. Do they come in different tension?
Yes, and that's based on the size of the esophagus.
Okay.
So we have a method of assessing the size of the esophagus in the person, and then based on that, if it's tight, then there'll be more tension. If it's loose, there'll be less tension.
Okay.
And you can see how this prevents the acid from going up. Yet when the food is going down, because of the fact that the esophagus squeezes the food down, it creates what we call a bolus. It allows that part to spread open, and it allows the bolus to go down. And this procedure is a smaller procedure. It takes less time, but obviously it is a foreign body. So that's why some surgeons, myself included, prefer to do the fundoplication.
Right, it's cleaner.
Other patients, they're more interested in something that takes less time, is removable.
How does this link together? I'm picturing you putting it, but there's no way you can do that. You have to link this somehow.
Yes, so it's actually like a bracelet. So we place it behind the esophagus, and I actually have a video of it, but in the interest of time, if you want, I could show you the video, how that links together if you want to see it.
But it links similar to a bracelet.
It's similar to a bracelet.
Amazing.
So we put it in like a long chain, and then we close it like a bracelet around the esophagus.
What would be the number one reason to go for this rather than that big word you used?
The fundoplication?
Yes.
Yeah, I think it's patient preference. I think also that if somebody is not able to withstand surgery for long, like they're
older, maybe?
Yeah, older and have more comorbidities, then this is a shorter procedure.
Is there reasons beyond that in terms of cost as well?
So this particular part is not being covered by insurances, this particular device, and that can be a great limiting factor. But the other one, the fundoplication, is covered by all insurances.
Okay.
Next one. And this actually shows you the bracelet. You can see that here, this is where the clasp of the bracelet is, almost like how you put a bracelet around your wrist, so this opens up and then you clasp it there. One of the downsides of having the links is that if the MRI is more than 1.5 Tesla, then it can destroy the magnets. So then they won't be effective anymore. So that's one of the drawbacks of having a lynx, and that's one of the reasons why I prefer the fundoplication.
Okay.
Next one. So basically, what I wanted to say was, patients who have long-standing acid reflux, instead of staying on medication for the rest of their lives, continuing to have side effects from those medications, some of which are not immediately apparent, but develop over time, and continuing to regurgitate, we do have better options for them. One is the fundoplication, where we take this part of the stomach and we wrap it around the esophagus and repair the hiatal hernia. It's a mechanical problem that calls for a mechanical solution, or having the LINX device. So we have these two options for these patients. And we at our reflux and hiatal hernia centers at St. Charles and St. Catherine of Siena, we have a focus on this. So we have a dedicated coordinator, we have dedicated, services and staff to help to promote this thing and to facilitate it, and for it to reach a level of expertise and excellence that we think that this increased focus has brought. Myself, I've been involved in this kind of surgery for more than 20 years, and it's been a great interest of mine right from the beginning, because I felt like this is an operation that we can do extremely well, and we can help patients resolve this problem, which is currently there's a great unmet need here. And we feel that, the administration at St. Charles and St. Catherine, met with me and said that there's an unmet need here, and let's try to fulfill this. And I think that we are achieving that goal.
Excellent work, doctor. Really, I'm very, very impressed.
You. Yeah.
Your experience is second to none, really. Question: do you ever see it in children?
Yes, reflux does occur in children, and in children, it's more of a bigger problem because they reflux a lot. I mean, obviously, babies are always burping and refluxing, but once it proceeds on to adulthood, then we have to treat it.
So tell me about some success stories.
So I routinely see patients who come in with severe acid reflux. They're regurgitating. Their quality of life is horrible because they can't sleep flat at night. After a meal, when they bend down to pick up something or tie their shoelaces, there's liquid coming up. And it's completely life-changing for these patients because we fix the mechanical problem, which is the valve at the lower end, and the fact that they have a hiatal hernia, which is causing all these issues. So patients are extremely satisfied with this. I particularly remember a 13-year-old girl who was constantly hiccuping and regurgitating and having a lot of symptoms. And her mother came to my office one day, and she came for something else. And she saw this brochure sitting there, and she said, "That's what my daughter has." And then I had a look at her, and I studied her, did her investigations, and we fixed her with a fundoplication, and now she's singing in the church choir.
Oh, wonderful.
Yeah.
That's a success story.
Yeah. It's very gratifying to be able to help patients.
Yeah, you're increasing quality of life tremendously.
Yeah.
And 1 out of 5 Americans is 20%. So this is not something that you see only sometimes. This is pretty prevalent.
Yeah.
Well, thanks for all you do.
Thank
On
you.
behalf of St. Charles and St. Catherine, keep up the good work.
Thank you.
And we'll put your contact information down at the bottom so people can enjoy your services, so to speak. Thank you, doctor.
Thank you for having me.
Thank you.